Thank you, first of all, Dada, and other panelists, and also my colleague from RP Center for Family Sciences, and Dr. Senjam is here. I talked once with you, sir. You must be surprising to know that how I land up in this services, low vision and visual disability. So initial 7 years I worked in the RP Center as a faculty in community ophthalmology. So I work a lot in terms of blindness survey, audits ICAM, school vision screening program, a lot of parliament question and preparation of the Ministry of Guidelines. There's so many things. So this seems to be keep repeating over the last few years. Then I feel so bored. And 2017 onward, when I returned from London, then I visited two centers in London. There is a RNIB, Royal National Institute for the Blind. And I observed there are so many devices, so many vision assistive devices. There are thousands. The area of that area is, 10 times of this room. And then I surprised how come this such center is not there in RP Center AIMS. Then when I returned, I discussed with my senior colleague and our chief. Then I said that we should have this kind of center. And then I have shown all the evidences, photo and everything. Then slowly I have started this clinic. That LVR clinic, that's low vision and rehabilitation clinic. So now we have a full-fledged clinics that's supported by the WHO and other external agencies. So my talk is my ideas with low vision patient and subsequent different observation, then vision assistive device. So let's start with a case study. This is a ROP SILE. See, so you might have seen this picture. This is ROP 5 both distributed, both positive, and the child at the age of 3 years and 6 months. This child has never seen how people walk. इंसान कैसे चलते हो दिखी नहीं है. So whether we should do anything for the child, whether we should do something for the child. Second is, this is another example, Tara, 25 years old, and secondary glaucoma with Hill uveitis, and with the BCV is left eye is no PL, and right eye is at 360. And the same after the hereditary macular degeneration, and the BCV is less than 3/60. So what when we are supposed to do this kind of patients when they come to your clinic? So my talks, first I will cover the patient care in terms of visual disability and vision assistive device. So now, rather than saying the low vision device, low vision aids, so we should expand our scope saying that vision assistive device. That includes the entire range of, you have low vision device for the blind, there's so many optical, electronics, software, hardware, so many things. So the vision assistive device is the right time that WHO is recommending now. So networking with the NGO is so important, as Dr. Senjam says. The low vision is not only the clinical and assessment. At the same time, you prescribe the sunglasses. It's not the end of our job. So you have to think about some other aspects about the livelihood, about the social problem. So the low vision itself is a medical problem as well as a social problem. So that means you have to manage both. You cannot confine to the medical problem only. So you have to expand the management towards the social problems. So for that, we have to make a network, because we work in the hospital. So we have to network, we have to prepare a networking system with the NGOs, existing NGOs in your community, because they have been providing the social services. Otherwise, you will be a monodisciplinary service. And first, training and capacity building is so important for our residents and the optometry students. This is the clinic I have started in 2017. So every mornings I orient our staff, and of course that our residents, the doctors also, or optometrists also. These are the range of the assistive devices I do have in the clinics, and very high end also we call it HMD devices, the head mounted display devices, which based on the AR and AI ways. So this is the flow chart I mentioned. The first patient come to our registration clinic, and we record all the informations. And the first thing is we do a need assessment. And once you do the need assessment, then you further go whether the patient needs a disability certificate, whether the patient needs the admission to the school, the vocational training center, apart from the clinical assessment. So the range of needs you will find out, and then according to the needs, then you have to categorize it and tailor the services. So the range of manual we have developed, so I'm not going to details. Education and counseling is so important, because acceptance is sometimes very problem. So people doesn't ready to accept. And this is a vision assistive device training. See, device training is so important. So prescribing, recommending a low vision aids is not the end of our job. So you have to provide some kind of training, how to use it, how to handle it, how to maintain it. At the same time, the repairing and the maintenance also. So reading stand at the side, you'll see So if the patient is not use reading stand while using a dome, so then she or she will look down whenever she reads, and then over time she might develop some kind of scoliosis. That's the problem. So range of assistive device, vision assistive device training. So this is the Vector Reader, DAISY book, and smartphone is nowadays very much coming up. Those are accessible apps, special apps for the smartphone. You know, a blind person, a low vision person can, you know, access the smartphone and contains the reads using the smartphone apps. And the picture is like this one is the trial using some kind of high-end devices. So that this is very important. This is one area in our clinic. So online application for visual disability certificates. Nowadays, everything is an online application. So because sometimes patients face, because they don't see properly, so how can they apply online? So we have, so far there are around 350 patients we support in terms of online application for disability certificates. And after that, the UDID certificate as well. And this rehabilitation services, in the first slide I have shown you that ROP child with a stair 5. So the mobility. So the rehabilitation service is so important for the congenital blindness or ROP, because the rehabilitation service is, you know, later on the child will be able to sustain, so able to live independently. So this simple rehabilitation service is something like learning how to do something for the first time. So it helps the child to develop the skills, maybe academic, maybe participation, maybe self-confidence, development, social skills. There are a range of skills that a human can develop. So if you provide the rehabilitation services early, then the children will be you know, easier to cope up his life, her life. So in the clinic, so you will not find this in the book. So somehow we interact frequently with the patient, with the parents, with the caregiver. Then somehow we categorize into two different forms for the rehabilitation services. The first is essential life skills. The second one is instrumental life skills. In the essential life skills, first we provide the rehabilitation service for the mobility and a social smile, because a child with the blind, so how to make a social smile, because a child smile in front of the parent, it means a lot. So and the communication training, because it's very difficult to train. You know, so these are very important steps, a milestone for a child born with the blind. And the instrumental life skills is object permanence, objects identification. It's very, very important. How to, you know, how to make identify child. This is the object, this is the spoon, this is the glass, something like that. So this is the last few slides. So this is the rehabilitation for mobility. The child is Arab, 2 years. 2 साल के बच्चे तो आजकल दौड़ते हैं. Child is not able to walk properly. So we divided into two parent techniques. So somehow the parents, mother and father, we ask them to stand at least 2-3 steps apart. So somehow we are able to provide. But of course, we have to see some kind of outcome over time. So we also distributed many walking can and magnifier as well to the patients who are very, very poor, poorest of the poor patient. And this is staff training for our optometry students and the resident doctors, MD students. And the vocational training is another important aspect. So we have to give a lot of information about this vocational, because the livelihood is very, very critical for them. This is the outcome. So social admission we refer, vocational training we refer, and school admission done, and vocational training done, because this is outcome from the networking services. We make a network with the NGOs in Delhi and the NCR, and we provide awareness about the scheme. And this is the financial support to the person with the visual disability. They have to apply for loan. And this is the last slide. See that this the first slide, Tara Kumari. So finally we contact this Blind Relief Association, because there's an NGO very popular in Delhi. So then this Tara visited this BRA, and then she found out that this activity, this employment is very important for me. So she chose a massage therapy, but now she is undergoing massage therapy. And this is from Rajasthan. So we provide orientation for the JOS and NBDA in the computer use. And then he got selected in LDC in Rajasthan Electric Board. And similarly, this is another girls from the BRA. So a successful story. And this is the last slide. So the first is Mohit. He got job for the MTS and the Ministry of Social Labor Welfare. Second, and the Ministry of Communication. Third, MTS in Ministry of Action and Affairs. Fourth, the same lady is doing in a massage therapy course.